Can you see me and hear me? Just drop a thumbs up in the chat. Okay. So let's start. That is like, firstly, hi Achievers. Myself, Dr. Vikram. Today I'm here for the discussion on the topic of physiology as a smart revision. That is like we will be discussing very frequently asked questions. Um Firstly, starting with the hormones, that is like growth hormone. It is going to be like excessive amount of the growth hormone is going to cause the gigantism and hypersecretion of the growth hormone in childhood before the fusion of the epiphysis of the bone. That is before the closure of the shaft, it is going to cause this gigantism. Whereas after the growth has been completed, then it is going to result into acromegaly. That is hypersecretion of the growth hormone in adults and enlargements of the bones, especially mandible, kyphosis, and also bulldog skull are the important features of the it. Whereas hyposecretion, that means less amount of growth hormone is secreted, then it is going to cause the dwarfism. That is hyposecretion of the growth hormone in the infancy or early childhood and stunted birth proportionated. That is like all the body parts are in same proportion. Growth with the normal mental activity and reproductive functions are important feature. And generally, body proportion is that we do have a golden proportion. That is like each and every body part in our organ is divided as according to golden proportion. This is similar to the smile designing that we do in the like in the adults, right? We do smile designing. There also we do follow this golden proportion and acromicria. That is like deficiency of growth hormone in adults, and it is characterized by atrophy of extremities of the body. And oral effects of this growth hormone is that large mandible, extreme pronathism, that is in the hypersecretion, it is going to cause pronathism, giving the head typical acromegalic appearance. Macroglossia, small dental arches resulting in a malocclusion, shorter roots, small mandible, and retarded eruption of shedding of the teeth is going to see. Coming to the parathormone, this is the hormone that is important also like that is like it is going to control the calcium level in the blood, right? So thereby the tetany is due to the hypoparathyroidism. That is like if at all parathormone is secreted in lesser rate in the thyroid gland, then it is going to cause an hypoparathyroidism, and that is going to be tetany, which occurs in the plasma calcium level that falls below the 6 milligram from its normal value of 9.4 milligrams per uh, percentage. And whereas it is going to be under having a clinical conditions of carpopedal spasm, trozosign, and sign are important feature of the tetany. Come into the like bone conditions, that is like bone disease like osteitis, fibrosia, cystica are important features of the hyperparathyroidism. That is like hypersecretion of the parathormone. And giant cell tumor or cyst of the jaws is going to be, or also brown tumors is going to occur. And loss of lamina dura, ground glass appearance of the bone is to be seen. See, these are like, yes, sorry. Abdul Rahman, can you please mute yourself? Yeah,
Yes, sir. Sorry.
yeah, okay, okay. See, firstly, these are the things they're going to ask you like clinical based questions. Like they can give you like a person is diagnosed with so and so conditions and as in a this science, that science, and like that they're going to ask you. Suppose like they can ask you a 34-year-old male patient is having an a carpopedal spasm, trozo signs, Schwarzschild signs. Then they're going to ask you what is the condition that is present or what is the patient is suffering from. Then we can say that it is a tetany that is occurring due to the deficiency of path hormone or the deficiency of calcium level in the blood. So thereby it is going to result into tetany. And one of the factors is going to be path hormone. Coming to the thyroid hormones, that is like hypothyroidism, hypothyroidism. In hyperthyroidism, that is like excessive secretion of the thyroid hormones. It is going to cause the thyroid adenoma, Graves' autoimmune disease, or common causes. And it is going to have two types, primary and secondary. Hypothyroidism is cretinism in children. See, this is very, 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 very important thing that is like cretinism is due to hypothyroidism in children, whereas myxedema is due to hypothyroidism in the adults. They can ask definitely one question from this kind of confusing things that is like cretinism in the children's, myxedema in adults, and also that is like a growth hormone deficiency, sorry, hypersecretion in the adults, and also hypersecretion in the children's. Hypersecretion in the children's is going to cause a gigantism, right? So and also so these are and acromegaly in the adults. See, these are the very confusing things, and at the same time, they are going to ask you these confusing questions. That is like in the children's what happens, in the adults what happens. And oral effects are that is a delayed eruption of the teeth, macroglossia, and swollen lips. And also there is seen of earlier shedding of the deciduous teeth and accelerated eruption of the permanent teeth. This is one of the very, very important things that is seen in the hypothyroidism. That is like due to less secretion of the thyroid hormone, it is going to be occur. Coming to the hyperaldosteronism, that is like firstly, hyperaldosteronism is due to the excessive secretion of the aldosterone, and it is classified as primary and secondary types. And the primary aldosteronism is going to be concerned with the Cone syndrome and develops due to the tumor in the zona glomerulosa of the adrenal cortex. Whereas in secondary aldosteronism is going to be concerned with due to external adrenal causes. And oral effects are deep chocolate pigmentation of the oral mucosa and pale brown is seen. And oral effects are also going to be gingiva is going to have deep chocolate pigmentation, tongue, and also on the lips. Coming to the insulin, that is like, see, this is the hormone that is secreted from the pancreas, right? And this is due to diabetes mellitus is due to the reduced secretion of the insulin by beta cells of islets of the Langerhans. This is a basic fundamental thing that we have been studying from the and polypeptide hormone that is mainly secreted by the beta cells in the islets of Langerhans of the pancreas, and the hormone potentially coordinates with the glucagon to modulate the blood glucose levels. Insulin acts via an anabolic pathway, while glucagon performs the catabolic pathways. Okay, and the increased levels of sugar level is going to cause a polyuria, polydipsia, and polyphagia. And also, in severe conditions, the complication of the diabetes mellitus is going to be retinopathy, neuropathy, and nephropathy. This is one of the very, very importantly asked question. That is like, what are the complications of the diabetes mellitus if at all it is going to be increased? Then the complication is going to be retinopathy, nephropathy, and neuropathy. And periodontitis, dry mouth, and multiple fleeting periodontal abscess is also seen. Coming to the diagnosis of the bleeding disorders of the screening test, that is like a platelet count, bleeding time, and also prothrombin time and activated, that is activated prothrombin time and prothrombin levels and pre-assumptive diagnosis. That is like, see, if at all the platelet count is decreased and bleeding time is prolonged and activated prothrombin time is normal and also prothrombin levels are also normal, then it is going to be under the thrombocytopenia. Definitely one question is going to be come from this table, definitely. Because like, see, before we perform any kind of surgery or any kind of extractions or implant placements or any kind of like a even grade 3 mobile also, like we need to ask and take the complete medical history of the patient. That is like, is the healing of the patient is normal or not? If not, definitely it is going to land up in some other clinical situations. Definitely we can handle it. That is like a, with the help of like a eat methods and also like a electrocautery and also adrenaline, and also suturing methods, or also with use of extra activity only, we can place in the socket and they also we can compress. But at the same time, we should be knowing, suppose if not healing occurs, then what? That is why we need to know the diagnosis first, right? So these are the presumptive diagnosis, and the normal prolonged that is platelet count is normal, but bleeding time is prolonged, and activated prothrombin time is prolonged, but prothrombin level is also normal. Then it is going to be comes under the von Willebrand disease, whereas the thrombocytopenia is having a normal in both platelet, bleeding time, and also prothrombin time, whereas bleeding time is prolonged. And in intrinsic pathway, only activated prothrombin time is going to be increased. Whereas in extrinsic pathway, the prothrombin level is prolonged. That is, time of the prothrombin is going to be increased. And in common pathway, both activated prothrombin time and also prothrombin are going to be prolonged. And in the that is like factor 13 deficiency, then it is going to be all the factors are normal, but bleeding disorder is because of this deficiency of this factor 13. Coming to the that is our composition, that is like total water content in the body is about 65 percentage, of which 50 is present in the intracellular, that is within the cell, that is in the cytoplasm of the cell, and 15 percentage in the extracellular fluid. In that also, 10.5 percentage is present in the interstitial fluid and plasma, which is about 4.5 percentage of the body weight. They can ask you simple direct questions based on this topic. And also, average volume of the blood in the adults is about 5 liters. Blood is made up of formed elements and plasma liquid portion, right? This is a very fundamental thing. And the plasma is a straw colored fluid and contains 92% of the water, 8 to 9% of solids. Plasma without fibrinogen is going to be serum. You can see that is like serum is going to be plasma minus clotting factors. And RBC is a prenatal erythrocytes or erythropoiesis is going to occur for the first to second months is about mesoderm of the yolk sac, that is mesoblastic, and third to 15 months in the liver, spleen, that is hepatic, and 6 to 9 months is going to be from the red bone marrow and liver, which is called as myeloid stage. And after 20 years of life cycle, RBC are formed by all membranous bones. That is like even our mandibular bone is also helps in the formation of the RBCs. Coming to the erythropoiesis factors, that is like erythropoietin, hormone, and also vitamin B12, folic acid, and Barca promoting activity and iron are the predisposing factors which are required for the erythropoiesis to occur. And erythropoietin is an hormone that is secreted by the extraglomerular apparatus of the nephron of the kidney, and it is excreted when oxygen supply is decreased to the kidney and the renal hypoxia condition occurs. It causes the formation and release of the new RBCs into the circulation. That is like if at all there is a renal hypoxia, that means the reduced supply of the oxygen to the renal tissues. Then what is going to do? It is the gustoglomerular apparatus is going to secrete the erythropoietin hormone, which is going to act on the that is like a event of our RBC forming cells, that is thereby initiating the erythropoiesis, and thereby RBCs are supplied in the circulation, which will be carrying the oxygen. So thereby the situation can be reversed back. And hemoglobin is a conjugated protein that is of heme part and globin part. In the day before class, we have discussed it, right? That is beta thalassemia. Because, right, in that RBC, that is like hemoglobin, is made up of two chains, that is alpha chains and beta chains, each consisting of two subchains, that is two alpha and two beta, where each chain is going to be 141 amino acids in the alpha and 146 amino acids in the beta one. The pigment is that is protoporphyrin formed by the four pyrrole rings or tetrapyrrole. That is means C. Four means tetra, right? So thereby tetrapyrrole ring is going to be formed. In adult male, 15 grams is seen, and in the females, it is going to be about 14.5 gram percentage. Coming to the destruction of the RBC, that is like hemoglobin is going to be destroyed into two parts, that is globin part and heme part. And the globin part enters into the amino acid pool, whereas heme part splits into remaining part and the iron part. Iron part is absorbed because our body needs it, and the remaining part is going to be converted into biliverdin and bilirubin and thereby excreted in the bile. And this is one of the very frequently asked questions, that is like, see, a child of 2 months old child who is feeding on the mother's milk that is completely white, but still the stool of the child is about yellow in color or blackish in color. Why? Because of biliverdin and bilirubin pigments that are secreted from the heme part. Okay, so this is one of the very frequently asked question also. Coming to the duration of the cardiac cycle, it is about zero point 0.8 seconds, and the duration of systole is about zero point 0.2 seconds, and diastole is 0.53 seconds. Systole consists of two divisions, diastole consists of five subdivisions. There is the systole, the two parts is going to be isometric contraction, ejection period, where the diastole is going to be protodiastole, isometric relaxation, rapid filling, slow filling, and atrial systole. And the duration of the isometric contraction is about 0.05 and ejection period is about 0.22. So totally it is going to be 0.27, and ventricular diastole is about protodiastole, that is zero point 0.04, isometric relaxation is 0.08, rapid filling 0.11, and slow filling is going to be 0.19, and last rapid filling is going to be 0.11, and it's about 0.53 seconds. So totally we can get in about zero point 0.8 seconds. And art sounds, see, very frequently asked also these questions, that is like art sounds. See, first and second art sound are, we are well versed at, that is love and from the our childhood. But the third and fourth art sound are heard only in under the pathological conditions. It occurs during the rapid filling phase, third and fourth, whereas fourth one is during the atrial systole. Characteristic is that low pitched sound, and it is inaudible in the fourth art sound. The cause are rushing of the blood into the ventricle, and the fourth art sound is because of the contraction of the atrial musculature. That is why atrial systole, right? So the contraction of the atrial muscles, and it is going to be about 0.02 to 0.04, whereas in third art sound is about 0.07 to zero point 0.1, and frequency is about 1 to 6 per second, and fourth out sound is going to be 1 to 4. And the relation to ECG is that it is seen between the T wave and P wave, whereas it is seen in between the P and Q wave. And number of vibrations that are seen in the phonocardiogram is going to be 1 to 4 and 1 to 2. These are first and second out sound are well versatile with all of you guys, right? Coming to the ECG, this is also one of the very, very, very frequently asked one, and also very like memorized one also. That is like, firstly, that is like ECG is divided into P wave, QRS complex, ST segment, and T wave. And this is the PR interval, QRS complex. They can simply ask simple direct question, that is like, what is this question mark? Most commonly, they will be asking you like a very direct question. See, in the medical part of our NEET MDS exam, most of the time they ask you like direct questions. But in the dental part, they will be giving in a case scenarios. That is like, a person is diagnosed with a so and so condition, so and so like symptoms have been seen. So what is the final diagnosis going to be? Like that they are going to ask. But in the most of the dental, that's medical part, they are going to ask you like direct questions. Most of the time, that is like out of 100 questions, about 60 to 80 questions going to be direct questions, and 20 questions is going to be somewhat twisty kind of questions are going to be. Coming to the waves of the normal ECG, that is like, see, P wave is concerned with atrial depolarization, and duration is going to be zero point 0.1 second, and amplitude is about 0.1 to 0.12 seconds, whereas QRS complex is the onset of Q wave to the end of S wave. And the cause is ventricular depolarization and atrial repolarization. And the duration is about 0.08 to 0.1. where the Q is about point 0.1 to point 0.2. Not they are not going to ask you detail till here, but like T wave is concerned with ventricular repolarization duration 0.2 seconds, and PR interval onset of P wave to the onset of Q wave, and atrial depolarization and conduction through the AV node, and the duration is going to be 0.18, and QT interval is about onset of Q wave and end of T wave. Ventricular depolarization and ventricular repolarization is going to be about zero point 0.4 to 0.42 seconds. And ST segment is about the end of S wave and onset of T wave. And the cause is because of isoelectric. And the duration is about 0.08 seconds. See, in our orientation class, we have discussed about out of 240 questions in the NEET MDS exam, they are going to be about 140 questions are going to be very easy ones, and remaining 60 plus 40 is going to be 120, 100 questions are the somewhat tricky ones. And if at all we focus on all the important points and all cover the frequently asked ones and also like a few important clinical concepts, then definitely we can cross this 140 baseline question mark. That is like we can go up to 140 correct questions. So definitely we thereby we can get in a good seat. If 140 into 5 is equals to somewhere around 400 plus 560, I guess. So that is like pretty good. But if you want to GDC, then definitely you have to watch each and every video that we have made, because like in each and we have been went into under depth in each and every concept. So they, if at all any question is going to be asked, definitely from these topics only, because there's they are not going to ask you from out of the textbooks. Whatever the textbooks are present, we have converted them into the PPT and thereby we made into videos. So once you cover them, definitely you can cross the limit. That is like 140 you are going to cross. But if at all, if you want to enter in a, like a just you want to get in any of the seat, then definitely you have to be making like cautious, and also like you have to cover all these topics that we are covering. And very important thing is that the Tuesday class that is going to be oral path. OPATH is going to be OPATH and oral medicine. It is going to be about 2 hour session definitely, and a lot amount of questions are going to be from this topic. Definitely, there are 25 to 30 questions are going to be come from that one particular seminar. Coming to the normal values, that is like systolic pressure is going to be 120 mm of Hg, and the range is going to be about 110 to 140. And the diastolic pressure is about 80 mm of Hg, and range is about 60 to 80 mm of Hg. And pulse pressure is about 120 to 80 mm of Hg, and the difference that is minus 120 minus 80 is going to be 40 mm of Hg is going to be the pulse pressure, whereas the mean atrial pressure is going to be 93 mm of Hg. That is by started by formula diastolic pressure plus pulse by 3. Like that, they're going to sorry, pulse by 6. Like that, sorry, it's 3. Pulse pressure by 3. Thereby, you going to get the mean atrial pressure. Cause of the cardiac murmur is that types of murmur is going to be two types: systolic murmur, diastolic murmur, and continuous murmur. The systolic murmur is going to be incompetence of atrioventricular valves, stenosis of the semilunar valves, anemia, septal defect, and coarctation of the aorta. And diastolic murmur is about the stenosis of the atrioventricular valves, incompetence of the semilunar valves, and continuous murmur is going to be because of patent ductus arteriosus. See, this is the sympathetic and parasympathetic supply of the GI tract. That is like parasympathetic one is going to be vagus nerve, which is going to supply the esophagus, stomach, small intestine. large intestine, and pelvic. Whereas sympathetic nerves, that is celiac ganglion, from the thoracic region is going to supply the stomach and the small intestine. Whereas from the lumbar region, that is superior mesenteric ganglion and inferior mesenteric ganglion, that is going to supply the large intestine. Coming to the digestive enzymes of the saliva that is secreted, this is a very important thing. That is parasympathetic supply to the maxillary and sublingual glands are submaxillary and sublingual glands are from the superior salivatory nucleus to the nervous intermediates of the Vrisberg, geniculate ganglion, facial nerve, chora tympani, and from there through the preganglion fibers, which is going to carry the impulses via lingual nerve to the submaxillary ganglion and thereby supplying the submaxillary gland and sublingual gland. Whereas the parasympathetic nerve supply to the parotid gland is going to be inferior salivatory nucleus. Here, superior salivatory nucleus. Whereas over here, inferior salivatory nucleus. And there is involvement of ninth, that is a glossopharyngeal nerve. Whereas over here, there is going to involvement of facial nerve. And the tympanic branch, from where the tympanic plexus, lesser petrosal nerve, sorry, that's a petrosal nerve, otic ganglion, postganglionic fibers that is carried into the parotid gland. This is one of the very frequently asked for the two differentiating questions. And also the composition of saliva is going to be salivary amylase. That is, enzymes are going to be salivary amylase, maltase, and lingual lipase. Whereas the source of secretion is going to be salivary amylase is secreted by all salivary glands, and maltase by major salivary glands, and the lingual lipase by lingual glands, and the activated medium is the acidic medium, and the action is going to be amylase is going to convert the starch into maltose, whereas lactase is going to convert the maltose. Sorry, the maltase is going to convert the maltose to glucose, and the lingual lipase is going to digest the fats into fatty acids and diacyl glycerol. Coming to the gastric juice and composition, that is like it is about made up of water 99.5 percentage and solids of about 0.5 percentage. The organic substances is going to be about enzymes, that is pepsin, rennin, gastric lipase, and gelatinase and urease. Whereas other organic substances are about mucus and intrinsic factor. See, the mucus is very, very important thing in the gastric juice because like without this in the gastric juice, it is going to be cause an gastric ulcers because of the damage from the strongest acid that is HCl. And the inorganic substances are about hydrochloric acid, sodium, calcium, potassium, and bicarbonate, chloride, phosphate, and sulfate. See, this is one of the very important thing. They are going to ask you the this is like secretion of the HCl in the parietal cells of the gastric gland. See, firstly, we all think that H2SO4 is the strongest acid ever known because like the common name of H2SO4 is the king of acids, right? But the name has been given to the H2SO4 because it has a wide implications in the industries. So that's why they call it as a king of acids. Whereas HCl is the actual strongest acid ever known, with a pH going to be 1 and also molarity also going to be 1, and which gives it an acidic nature. And the question that comes is our body going to defend ourselves, and also our body is going to secrete this strongest acid ever known. That is because, see, the basic structure of the HCl is about H plus and Cl minus. So the H plus ion that is formed from the H2CO3, which splits into HCO3 minus and H plus ion in the parietal cells, and NaCl will be donating the sodium and chloride, and this chloride ion will be entering into the parietal cells where they will be crossing the parietal cell and enter into the lumen of the stomach. So here in the lumen itself, there is a formation of H plus. That is, the acid is going to be formed in the lumen of the stomach. Not that is like it is secreted somewhere and transported to some other body part or transported to the lumen of the stomach. But it is produced then and also utilized there itself. So thereby, at the same time, the mucus, the secretion is very, very important to defend our body from this strongest acid, which will be secreted in large amounts, and thereby these acidic concentrations are diluted by the time it reaches the mucosal cells. And that is the reason why the people will be having an ulcer. That is, ulcers, if at all the people is not having a diet on regular time. Suppose if a person is not having any diet for 1 to 2 days, then what happens? The HCl is secreted. What will it will do? If at all food is present, it will be digesting the food. But if food is not present, then what it will be do? It will digesting the our mucus, followed by the parietal cells, and thereby the cells of the gastric glands, and also there is a stomach cells. Coming to pancreatic juice, it is about 500 to 800 ml of day. That is like it is secreted in the quantity of about 500 to 800 ml per day, and alkaline in nature with a pH of about 8 to 8.3. The pancreatic juice contains about 99.5% of water and 0.5% of solids. And the solids are going to be proteolytic enzymes, lipolytic enzymes, and amylolytic enzymes, that is pancreatic amylase. And the lipolytic enzymes are pancreatic lipase and phospholipase. Proteolytic enzymes are the trypsin, chymotrypsin, carboxypeptidase, elastase, nuclease, and collagenase. The enterokinase of the duodenum, and by autocatalytic action, that is like it will be activating the inactive trypsinogen into trypsin, and trypsin is the most powerful protein splitting enzyme. By means of hydrolysis, it converts the proteins into proteases and polypeptides. That is like the protein molecules are split into proteases and polypeptides. The trypsin also converts the chymotrypsinogen to the chymotrypsin, and the proelastase into elastase, and procolipase to the colipase, sorry. Coming to the digestive enzymes of the pancreas, that is pancreatic juice, and their activity. That is like trypsin. The activity is going to be enterokinase, and also the trypsin that is once formed will be auto-activating the inactive trypsinogen into active trypsin. So that's why it is called as autocatalytic enzyme. And the action is going to be act on the proteins, and the end products are proteoses and polypeptides. Chymotrypsin is going to be activated by the trypsin, and proteins are converted to polypeptides. And the nucleases, see, this is nucleases are secreted only in the pancreatic juice. That is, nucleases are activated by the trypsin, where they will be digesting the RNA and DNA, and end products are the mononucleotides. That is NADP. And the elastase is going to be the trypsin, elastin, and amino acids. Collagenase is going to be activated by trypsin and going to digest the collagen. Pancreatic lipase going to be acting on the triglycerides, that is like fatty substances, and cholesterol ester hydrolase are going to be digested by the cholesterol ester, and they are digested in the alkaline medium. And phospholipase going to be activated by trypsin. See, trypsin is very much active, important thing. It will be activating almost all the enzymes of the pancreatic juice, and they are going to exhibit the respective activity. Bile salt activated lipase, it is going to act on the substrate, that is phospholipids, cholesterol esters, triglycerides, and the lysophospholipids are going to the end products after digesting of the phospholipids, whereas after digesting the cholesterol esters, the cholesterol and fatty acids are formed, whereas triglycerides, after digesting, they are going to be formation of monoglycerides and fatty acids. whereas pancreatic amylase is going to convert the starch into dextrin and maltose. See, the end product of the digestion is that monomer units. That is like glucose, fructose, lactose, and also our that is like in the proteins, it is going to be amino acids. In the fats, it is going to be glycerides and fatty acids are going to be the end products. And the hormones of GIT are that is gastrin secreted by G cells in the pyloric glands of the stomach, and enterogastrin is going to be duodenal mucosa, and cholecystokinin is the eye cells of the duodenum and jejunum and ileum, where secretin is secreted by S cells of the duodenum, jejunum, and ileum. Enterocrinin is the duodenum in response to the partially digested food from the stomach. Gastric inhibitory peptide is going to be secreted by K cells in the duodenum and jejunum, and vasoactive intestinal polypeptide is going to be secreted by the stomach, small and large intestines, whereas somatostatin is going to be secreted by hypothalamus, D cells of the islets of the Langerhans of the pancreas. Coming to the cholecystokinin and pancreazymin, this is one of the very, very frequently asked question. That is like